Hello, today's topic is tuberculosis, epidemiology, etiology, pathogenesis, and specific immune response. TB is one of the top 10 causes of death worldwide. The WHO estimates that more than 10 million new cases of TB occurred worldwide in 2016. 95% of them in developing countries of Asia, Africa, the Middle East, and Latin America. 7 countries accounted for 64% of all new cases are India, Indonesia, China, the Philippines, Pakistan, Nigeria, and South Africa. Two-thirds of cases typically occur in male patients, and more than 1 million children are affected every year. It's further estimated that 1.7 million deaths from TB, including 0.37 million among people with HIV infection, occurred in 2016. 96% of these deaths were in developing countries. You can see here estimated TB incidence rates per 100,000 population in 2016, and also estimated TB mortality rates, excluding TB-related deaths among HIV-positive people in 2016. The role of WHO in TB management is very important for national TB programs at country levels. And you must remember that TB management is absolutely free. The etiologic agent of TB is Mycobacterium tuberculosis. The most common and important agent of human disease is Mycobacterium tuberculosis. And here on this picture, you see how it looks like. Mycobacterium tuberculosis characterized with A, strict aerobe, acid fast, and B, code factor is virulence factor. How can we screening TB? With used purified protein derivative, PPD, intradermal skin test. But this test does not distinguish active from inactive disease. Protein and cell wall responsible for positive PPD. And about drug resistance. A, chromosome mutations involving mycolic acid, and B, chromosome mutations involving catalase peroxidase. Here you see how looks acid-fast bacillus smear of Mycobacterium tuberculosis bacilli. Acid fastness is mainly attributable to the organism's high content of mycolic acids, long-chain cross-linked fatty acids, and other cell wall lipids. And the mycobacterial cell wall lipids, for example, mycolic acids, are linked to underlying arabinogalactan and peptidoglycan. This structure confers very low permeability of the cell wall, thus reducing the effectiveness of most antibiotics. Here you see Mycobacterium tuberculosis cell surface. You see here mycolic acid, nearly 10 nanometers, then arabinogalactan, then peptidoglycan. Another molecule in the mycobacterial cell wall, lipoarabinomannan, is involved in the pathogen-host interaction and facilitates the survival of Mycobacterium tuberculosis within macrophages. The complete genome sequence of the Mycobacterium TB comprises 4,000 genes encoding 3,099 free proteins and 50 genes encoding RNAs. Its high guanine plus cytosine content is indicative of an aerobic lifestyle. A large proportion of genes are devoted to the production of enzymes involved in cell wall metabolism. Here you can see how different the gram-positive bacteria, gram-negative bacteria, and mycobacteria. Mycobacteria tuberculosis is most commonly transmitted from a person with infectious pulmonary TB to others by droplet nuclei, which are aerosolized by coughing, sneezing, or speaking. The tiny droplets dry rapidly. The smallest, less than 5 to 10 nanometers in diameter, may remain suspended in the air for several hours and may reach the terminal air passages when inhaled. There may be as many as 3,000 infections nuclei per cough. The most infectious patients have cavitary pulmonary disease, or much less commonly, laryngeal tuberculosis, and produce sputum containing as many as 105-107 acid-fast bacilli per milliliter. Less infections those with culture-negative pulmonary disease and extrapulmonary tuberculosis are essentially non-infectious, because persons with both HIV infection and TB are less likely to have cavitations. They may be less infectious than persons without HIV infection. Crowding in poorly ventilated rooms is one of the most important factors in the transmission of tubercle bacilli because it increases the intensity of contact with the case. In short, the risk of acquiring Mycobacterium tuberculosis infection is determined mainly by exogenous factors. Because of delays in seeking cure and in making a diagnosis, it's estimated that in high prevalence settings, up to 20 contacts may be infected by each AFP positive case before the index case is found to have TB. Here you see risk factors for active TB among persons who have been infected with tubercle bacilli. Unlike the risk of acquiring infection with Mycobacterium tuberculosis, the risk of developing disease after being infected depends largely on endogenous factors, such as the individual's innate immunologic and non-immunologic defense and level of function of cell-mediated immunity. The interaction of Mycobacterium tuberculosis with the human host begins when droplet nuclei containing microorganisms from infectious patients are inhaled. Although the majority of inhaled bacilli are trapped in the upper airways and expelled by ciliated mucosal cells, a fraction reach the alveoli, usually less than 10%. Their alveolar macrophages have not yet been activated to phagocytize the bacilli. Phagocytosis is enhanced by complement activation, leading to opsonization of bacilli with C3 activation products such as C3b. After a phagosome forms, the survival of Mycobacterium tuberculosis within it seems to depend on reduced acidification because of lack of accumulation of vesicular protonadenosine 3-phosphatase. Pathogenesis and immunity. A complex series of events is probably generated by the bacterial cell wall glycolipid lipoarabinomannan, LAM. LAM inhibits the intracellular increase of calcium 2+, thus the calcium 2+ calmodulin pathway, leading to phagosome-lysosome fusion, is impaired, and the bacilli may survive within the phagosomes. If the bacilli are successful in arresting phagosome maturation, then replication begins and the macrophage eventually ruptures and releases its bacillary contents. Clinical illness directly after infection is classified as primarily tuberculosis and is common among children up to 4 years of age and among immunocompromised persons. The majority of infected individuals who ultimately develop tuberculosis do so within the first year or two after infection. Dormant bacilli, however, may persist for years before reactivating to produce secondary or post-primary tuberculosis, which because of frequent cavitation is more often infectious than its primary disease. Overall, it's estimated that up to 10% of infected persons will eventually develop active tuberculosis in their lifetime. The risk is much higher among HIV-infected persons. The incidence of tuberculosis is highest during late adolescence and early adulthood. The reasons are unclear. The incidence among women peaks at 25-34 years of age. The risk may increase in elderly individuals, possibly because of waning immunity and comorbidity. In the initial stage of host-bacterium interaction, either fusion between phagosomes and lysosomes occurs, preventing bacillary survival, or the bacilli begin to multiply, ultimately killing the macrophage. A variety of chemoattractants that are released after cell lysis, for example, complement components, bacterial molecules, and cytokines, recruit additional immature monocyte-derived macrophages, including dendritic cells, which migrate to the draining lymph nodes and present mycobacterial antigens to T lymphocytes. At this point, the development of CMI and humoral immunity begins. These initial stages of infection are usually asymptomatic. About 2 to 4 weeks after infection, two host responses to Mycobacterium tuberculosis develop: A. Macrophage activating CMI response, a tissue damaging response. Here you see primary pulmonary tuberculosis from 0 to 3 weeks, and B. Primary pulmonary tuberculosis. The macrophage activating response is a T-cell mediated phenomenon resulting in the activation of macrophages that are capable of killing and digesting tubercle bacilli. The tissue damaging response is the result of a delayed type hypersensitivity DTH reaction to various bacillary antigens. It destroys unactivated macrophages that contain multiplying bacilli, but also causes caseous necrosis of the involved tissues. Now about some words of granuloma formation. With the development of specific immunity and the accumulation of large numbers of activated macrophages at the site of the primary lesion, granulomatous lesions or tubercles are formed. These lesions consist of accumulations of lymphocytes and activated macrophages that evolve toward epithelioid and giant cell morphologies. Here you can see macrophages, how they, then we see here in green color leukocytes and granuloma organized, and my active mycobacterial tuberculosis are get out from these granulomas, and the cycle is beginning again. CMI is critical at this early stage. In the majority of infected individuals, local macrophages are activated when bacillary antigens processed by macrophages stimulated T lymphocytes to release a variety of lymphokines. These activated macrophages aggregate around the lesion center and effectively neutralize tubercle bacilli without causing further tissue destruction. In the central part of the lesion, the necrotic material resembles soft cheese, caseous necrosis, a phenomenon that may also be observed in other conditions such as neoplasms. Here you see typical granuloma caused by Mycobacterium tuberculosis. Central granular cessation, they are surrounded by epithelial macrophages and multinucleate giant cells and peripheral accumulation of lymphocytes. The delayed type hypersensitivity reaction. In a minority of cases, the macrophage activating response is weak, and mycobacterial growth can be inhibited only by intensified DTH reactions, which lead to lung tissue destruction. The lesion tends to enlarge further and the surrounding tissue is progressively damaged. At the center of the lesion, the caseous material liquefies. Bronchial walls as well as blood vessels are invaded and destroyed, and cavities are formed. The liquefied caseous material containing large numbers of bacilli is drained through bronchi. Within the cavity, tubercle bacilli multiply, spill into the airways, and are discharged into the environment through expiratory manners such as coughing and talking. In the early stages of infection, bacilli are usually transported by macrophages to regional lymph nodes, from which they gain access to the bloodstream and disseminate widely throughout the body. The resulting lesions may undergo the same evolution as those in the lungs, although most tend to heal. In young children with poor natural immunity, hematogenous dissemination may result in fatal military tuberculosis or tuberculous meningitis. Although CMI confers partial protection against Mycobacterium tuberculosis, humoral immunity plays a less well-defined role in protection. In the case of CMI, two types of cells are essential: macrophages with directly phagocytized tubercle bacilli, T cells, mainly CD4 plus T lymphocytes, which induce protection throughout the production of cytokines. Now about the role of macrophages and monocytes. After infection with Mycobacterium tuberculosis, alveolar macrophages secrete various cytokines responsible for a number of events, for example, the formation of granulomas, as well as systemic effects. Monocytes and macrophages attracted to the site are key components of the immune response. Alveolar macrophages, monocytes, and dendritic cells are also critical in processing and presenting antigens to T lymphocytes, primarily CD4 plus and CD8 plus T cells. The result is the activation and proliferation of CD4 plus T lymphocytes, which are crucial to the host defense against Mycobacterium tuberculosis. Here you see activate macrophage bacterial activity, how Mycobacterium tuberculosis act. And at last we have caseous necrosis. Role of lymphocytes. Activated CD4 plus T lymphocytes can differentiate into cytokine production Th1 or Th2 cells. Th1 cells produce IF and gamma and activator of macrophages and monocytes, and IL-2, interleukin-2. Th2 cells produce interleukin-4, interleukin-5, and interleukin-10, and interleukin-13, and may promote humoral immunity. IFN gamma released by the CD4 plus T cells of the Th1 subset is crucial in activating macrophages. Activated macrophages in turn release a variety of mediators and upregulate expression of genes with important downstream effects, including tumor necrosis factor, which is responsible for recruitment of monocytes, which in turn undergo activation and differentiation into the epithelioid histiocytes. They characterize the granulomatous response. Expression of the inducible nitric oxide synthase gene, which results in elevated nitric oxide levels at the site of infection with excellent antibacterial activity. Generation of reactive oxygen species, which can have antibacterial activity. Defects in any of the steps of Th1 response, including interleukin-12, IFN gamma, TNF, or nitric oxide production, result in poorly formed granulomas, absence of resistance, and disease progression. In summary, immunity to a tubercular infection is primarily mediated by Th1 cells, which simulate macrophages to kill bacteria. You see here droplet nuclei containing tubercle bacilli are inhaled, enter the lungs, and travel to the alveoli. Tubercle bacilli multiply in the alveoli. A small number of tubercle bacilli enter the bloodstream and spread throughout the body. The tubercle bacilli may reach any part of the body, including areas where TB disease is more likely to develop, such as the brain, larynx, lymph node, lung, spine, bone, or kidney. Within 2 to 8 weeks, special immune cells called macrophages ingest and surround the tubercle bacilli. The cells form a barrier shell called a granuloma that keeps the bacilli contained and under control, LTBI, latent TB. If the immune system cannot keep the tubercle bacilli under control, the bacilli begin to multiply rapidly, and we have TB disease. This process can occur in different areas of the body, such as the lungs, kidneys, brain, or bone. Pulmonary tuberculosis can be categorized as primary or post-primary or secondary. Primary disease, primary pulmonary TB, occurs soon after the initial infection with tubercle bacilli. In areas of high tuberculosis transmission, this form of disease is often seen in children. Primary pulmonary TB occurs soon after the initial infection with tubercle bacilli. It may be asymptomatic or may present with fever and occasionally pleuritic chest pain. In areas of high TB transmission, this form of disease is often seen in children. Because most inspired air is distributed to the middle and lower lung zones, these areas are most commonly involved in primary TB. The lesion forming after infection is usually peripheral and accompanied in more than half of cases by hilar or paratracheal lymphadenopathy, which may not be detectable on chest radiography. In the majority of cases, the lesion heals spontaneously and may later be evident as a small calcified nodule, Ghon lesion. You see here on X-ray chest radiograph showing right hilar lymph node enlargement with infiltration into the surrounding lung tissue in a child with primary TB. In children and in persons with impaired immunity, for example, those with malnutrition or HIV infection, primary pulmonary tuberculosis may progress rapidly to clinical illness. The initial lesion increases in size and can evolve in different ways. Pleural effusion, which is found in up to 2/3 of cases, results from the penetration of bacilli into the pleural space from an adjacent subpleural focus. The Ghon focus, with or without overlaying pleural reaction, thickening, and regional lymphadenopathy, is referred to as the Ghon complex. You see here primary pulmonary tuberculosis Ghon complex, how it looks like. The gray-white parenchymal focus arrow is under the pleura in the lower part of the upper lobe. Hilar lymph nodes with cessation are seen on the left. Tuberculosis in young children is almost invariably accompanied by hilar or mediastinal lymphadenopathy caused by the spread of bacilli from the lung parenchyma through lymphatic vessels. Enlarged lymph nodes may compress bronchi, causing obstruction and subsequent segmental or lobar collapse. Lymph nodes may also rupture into the airway with development of pneumonia, often including areas of necrosis and cavitation, distal to the obstruction. Bronchiectasis may develop in any segment, lobe, damaged by progressive cessating pneumonia. Occult hematogenous dissemination commonly follows primary infection. However, in the absence of a sufficient acquired immune response, which usually contains the infection, disseminated or miliary disease may result. Small granulomatous lesions develop in multiply organs and may cause locally progressive disease or result in tuberculous meningitis. This is a particular concern in very young children and immunocompromised persons. For example, patients with HIV infections. You see here on chest radiograph, which showing bilateral miliary infiltrates in a child. Now about post-primary disease, also called adult-type reactivation or secondary TB. Post-primary disease results from endogenous reactivation of latent infection and is usually localized to the apical and posterior segments of the upper lobes, where the substantially higher mean oxygen tension, compared with that in the lower zones, favors mycobacterial growth. Here you see secondary pulmonary TB. The upper parts of both lungs are riddled with gray-white areas of cessation and multiply areas of softening and cavitation. The extent of lung parenchymal involvement varies greatly, from small infiltrates to extensive cavitary disease. With cavity formation, liquefied necrotic contents are ultimately discharged into the airways, resulting in satellite lesions within the lungs that may in turn undergo cavitation. Chest radiograph showing a right upper lobe infiltrate and a cavity with an air fluid level in a patient with active tuberculosis. See, this is the CT scan showing a large cavity in the right lung of a patient with active tuberculosis. Early in the course of disease, symptoms and signs are often nonspecific and insidious, consisting mainly of fever and night sweats, weight loss, anorexia, general malaise, and weakness. However, in the majority of cases, cough eventually develops often, initially non-productive and subsequently accompanied by the production of purulent sputum, sometimes with blood streaking. Massive hemoptysis may ensue as a consequence of the erosion of a blood vessel in the wall of a cavity. Hemoptysis, however, may also result from rupture of a dilated vessel in a cavity, Rasmussen's aneurysm, or from aspergilloma formation in an old cavity. Pleuritic chest pain sometimes develops in patients with subpleural parenchymal lesions. Extensive disease may produce dyspnea and, in rare instances, adult respiratory distress syndrome, ARDS. Now, physical findings are of limited use in pulmonary TB. Many patients have no abnormalities detectable by chest examination, but others have detectable rales in the involved areas during inspiration, especially after coughing. Occasionally, rhonchi caused by partial bronchial obstruction and classic amphoric breath sounds in areas with large cavities may be heard. Systemic features include fever of a low-grade and intermittent in up to 80% of cases and wasting. Absence of fever, however, does not exclude TB. In some cases, pallor and finger clubbing develop. The most common hematologic findings are mild anemia and leukocytosis. Hyponatremia caused by the syndrome of inappropriate secretion of antidiuretic hormone has also been reported. Now about criteria for the diagnosis of pulmonary TB. First of all, smear positive cases. At least 2 positive smears or 1 positive smear and radiographic abnormalities compatible with pulmonary tuberculosis, or 1 positive smear and 1 positive culture. Smear negative cases, at least 3 negative smears and 1 or more positive cultures, or at least 2 series of negative smears from samples taken at least 2 weeks apart with persisting radiographic abnormalities compatible with active tuberculosis, not improved with treatment using broad-spectrum antibiotics for at least 1 week. Now about certain radiographic abnormalities are consistent with TB. Nodules are round shadows or densities with clearly defined borders. Their size varies from a micronodule less than 3 mm in diameter to a nodule more than 3 mm and less than 1 cm in diameter to a round shadow more than 1 cm in diameter. Patchy shadows or infiltrations have irregular borders that are not as clearly defined. They are of varying size, sometimes extending to large parts of the lungs, and at least cavities. And finally, cavities. Cavities are the most characteristic signs of TB. A cavity is an area of lucency with a fairly thick wall, more than 1 millimeter, in which an area of bronchial drainage, demonstrated by opaque parallel lines. Opaque parallel lines may be evident at the pole closest to the hilum of the lung. Cavities sometimes contain liquid at the base, the liquefied caseous material, evident as an air fluid level. Now about practical points. Pulmonary tuberculosis cannot be diagnosed with certainty by radiography alone. If a radiography is suggestive of TB, bacteriological examinations must be requested. If a radiograph shows cavities but bacteriological examination is negative, the diagnosis of a condition other than active tuberculosis needs to be considered. Complications may be the first indication of tuberculosis or may occur as the disease develops. Hemoptysis can be light, moderate, or extensive. Massive hemoptysis caused by the erosion of an arterial wall is a rare but dramatic complication that can result in sudden death. Pneumothorax, caused by a rupture of a cavity into the pleural space, is a serious complication. Bacilli from the cavity can infect the pleural space, leading to pneumothorax. In the latter event, pleural drainage may be required in addition to anti-TB treatment. Contagious pleurosity can accompany active pulmonary TB. Bronchiectasis, repeated acute pulmonary infection, and hemoptysis are the most common manifestations. It should not be confused with recurrence of tuberculosis disease, which must always be confirmed by bacteriological examination. Chronic respiratory failure may occur in patients who have previously had extensive tuberculosis, in whom large parts of the lung have been destroyed. Pneumothorax may result from rupture of a bulla in association with lung scars. This type of pneumothorax does not lead to infection of the pleura. It's usually benign and can usually be relieved within 48 hours with simple medical treatment. Aspergilloma, due to infection by Aspergillus fumigatus of a healed cavity, may present with hemoptysis and often require surgical exertion. Conclusion. Pulmonary TB should always be considered in adults presenting with symptoms of the respiratory tract, cough and expectoration of sputum, lasting for more than 3 weeks. In countries with a high prevalence of TB, the majority of cases of pulmonary TB in adults are sputum smear positive. The diagnosis of TB in adults is therefore based on microscopy of sputum smear. Now about the extrapulmonary TB. In order of frequency, the extrapulmonary sites most commonly involved in TB are the lymph nodes, pleura, genitourinary tract, bones, and joints, meninges, peritoneum, and pericardium. However, virtually all organ systems may be affected. As a result of hematogenous dissemination in HIV-infected individuals, extrapulmonary TB is seen more commonly today than in the past. Lymph node TB or tuberculous lymphadenitis. Lymph node disease is particularly frequent among HIV-infected patients and among children. Lymph node TB presents as painless swelling of the lymph nodes, most commonly at posterior cervical and supraclavicular sites. The condition historically referred to as scrofula. Lymph nodes are usually discrete and non-tender in early disease, but may inflamed and have a fistulous tract-draining caseous material. You see here tuberculous lymphadenitis affecting the cervical lymph nodes in a 2-year-old child from Malawi. Associated pulmonary disease is seen in 40% of cases. Systemic symptoms are usually limited to HIV-infected patients. The diagnosis is established only by fine needle aspiration or surgical biopsy. Acid-fast bacilli are seen in up to 50% of cases. Cultures are positive in 70 to 80%, and histologic examination shows granulomatous lesions. Among HIV-infected patients, granulomas usually are not seen. The differential diagnosis includes a variety of infectious conditions, neoplastic diseases such as lymphomas or metastatic carcinomas, and rare disorders such as Kikuchi disease, necrotizing histiocytic lymphadenitis, Kimura's disease, and Castleman's disease. About pleural tuberculosis, depending on the extent of reactivity, the effusion may be small, remain unnoticed, and resolve spontaneously, or may be sufficiently large to cause symptoms such as fever, pleuritic chest pain, and dyspnea. Physical findings are those of pleural effusions, dullness to percussion, and absence of breath sounds. A chest radiograph reveals the effusion and in up to one-third of cases also shows a parenchymal lesion. Thoracentesis is required to ascertain the nature of the effusion and to differentiate it from manifestations of other etiologies. The fluid is straw-colored and at times hemorrhagic. It's an exudate with a protein concentration more than 50%. Of that in serum, usually for 6 grams of deciliter. A normal to low glucose concentration and detectable white blood cells. Neutrophils may predominate in the early stage, and mononuclear cells are the typical finding later. Mesothelial cells are generally rare or absent. Acid-fast bacilli are seen on direct smear in only 10 to 25% of cases, but cultures may be positive for the Mycobacteria tuberculosis in 25 to 75% of cases. Positive cultures are more common among post-primary cases. Determination of the pleural concentration of adenosine deaminase is a useful screening test. Tuberculosis is virtually excluded if the value is very low. Needle biopsy of the pleura is often required for diagnosis and reveals granulomas of yields a positive culture in up to 80% of cases. This form of pleural tuberculosis responds well to chemotherapy and may resolve spontaneously. The usefulness of glucocorticoid administration is doubtful. Tuberculosis empyema is a less common complication of pulmonary tuberculosis. It's usually the result of the rupture of a cavity with spillage of a large number of organisms into the pleural space. This process may create a bronchopleural fistula with evident air in the pleural space. A chest radiograph shows hydropneumothorax with an air fluid level. The pleural fluid is purulent and thick and contains large numbers of lymphocytes. Acid-fast smears and mycobacterial cultures are often positive. Surgical drainage is usually required as an adjunct to chemotherapy. Tuberculosis empyema may result in severe pleural fibrosis and restrictive lung disease. Removal of the thickened visceral pleura, decortication, is occasionally necessary to improve lung function. Tuberculosis of the upper airways, nearly always a complication of advanced cavitary pulmonary tuberculosis. Tuberculosis of the upper airways may involve the larynx, pharynx, and epiglottis. Symptoms include hoarseness, dysphonia, and dysphagia. In addition to chronic productive cough, findings depend on the site of involvement, and ulcerations may be seen on laryngoscopy. Acid-fast smear of the sputum is often positive, but biopsy may be necessary in some cases to establish the diagnosis. Carcinoma of the larynx may have similar features, but is usually painless. About genitourinary tuberculosis. Genitourinary tuberculosis may involve any portion of the genitourinary tract. Local symptoms predominate, and up to 1/3 of patients may concomitantly have pulmonary disease. Urinary frequency, dysuria, nocturia, hematuria, and flank of or abdominal pain are common presentations. Urine analysis given abnormal results in 19% of cases, revealing pyuria and hematuria. The documentation of culture-negative pyuria in acidic urine raises the suspicion of tuberculosis. Fourth, pyelography, intravenous pyelography, abdominal CT, or MRI may show deformities and obstructions and calcifications and urethral strictures and are suggestive findings. Culture of 3 morning urine specimens yields a definitive diagnosis in nearly 19% of cases. Severe urethral strictures may lead to hydronephrosis and renal damage. UCMRI culture confirmed renal TB, T2 latent coronary plaque, coronal sections showing several renal lesions in both the cortical and the medullary tissues of the right kidney. Genital TB is diagnosed more commonly in female than in male patients. In female patients, it affects the fallopian tubes and the endometrium and may cause infertility, pelvic pain, and menstrual abnormalities. Diagnosis requires biopsy or culture of specimen obtained by dilation and curettage. In male patients, tuberculosis preferentially affects the epididymis, producing a slightly tender mass that may drain externally, though a fistula tract, orchitis, and prostatitis may also develop. In almost half of cases of genitourinary tuberculosis, urinary tract disease is also present. Genitourinary tuberculosis responds well to chemotherapy. Now, about skeletal TB. In bone and joint disease, pathogenesis is related to reactivation of hematogenous foci or to spread from adjacent paravertebral lymph nodes. Weight-bearing joints are most commonly affected. Spinal tuberculosis, post-disease, or tuberculous spondylitis often involve 2 or more adjacent vertebral bodies. You see CT scan demonstrating destruction of the right pedicle of T10 due to post-disease. The patient, a 70-year-old Asian woman, presented with back pain and weight loss and had biopsy-proven TB. Although the upper thoracic spine is the most common site of spinal TB in children, the lower thoracic and upper lobar vertebrae are usually affected in adults. From the anterior, superior, or inferior angle of the vertebral body, the lesion slowly reaches the adjacent body, later affecting the intervertebral disc. With advanced diseases, collapse of vertebral bodies results in kyphosis, kibus. A paravertebral called abscess may also form in the upper spine. This abscess may track to and penetrate the chest wall, presenting as a soft tissue mass. In the lower spine, it may reach the inguinal ligaments or present as a psoas abscess. CT or MRI reveals the characteristic lesions and suggests its etiology. The differential diagnosis includes tumors and other infections. Pyogenic bacterial osteomyelitis, in particular, involves the disc very early and produces rapid sclerosis. Aspiration of the abscess or bone biopsy confirms the tuberculosis etiology because culture are usually positive and histologic findings highly typical. A catastrophic complication of post-disease is paraplegia, which is usually caused by an abscess or a lesion compressing the spinal cord. Paraparesis caused by a large abscess is a medical emergency and requires rapid drainage. Tuberculosis of the Hip joints, usually involving the head of the femur, causes pain. Tuberculosis of the knee produces pain and swelling. If the disease goes unrecognized, the joints may be destroyed. Tuberculosis of the knee. Diagnosis requires examination of the synovial fluid, which is thick in appearance with a high protein concentration and a variable cell count. Although synovial fluid culture is positive in a high percentage of cases, synovial biopsy and tissue culture may be necessary to establish the diagnosis. Tuberculosis, meningitis, and tuberculoma. Meningitis results from the hematogenous spread of primary or post-primary pulmonary disease or from the rupture of a subependymal tubercle into the subarachnoid space. In more than half of cases, evidence of old pulmonary lesions or a miliary pattern is found on chest radiograph. The disease often presents subtly as headache and slight mental changes after a prodrome or weeks of low-grade fever, malaise, anorexia, and irritability. If not recognized, tuberculous meningitis may evolve acutely with severe headache, confusion, lethargy, altered sensorium, and neck rigidity. Typically, the disease evolves over 1 to 2 weeks, a course longer than that of bacterial meningitis. Paresis of the cranial nerves is a frequent finding, and the involvement of the cerebral arteries may produce focal ischemia. The ultimate evolution is toward coma with hydrocephalus and intracranial hypertension. Lumbar puncture is the cornerstone of diagnosis. In general, examination of the cerebrospinal fluid, CSF, reveals a high leukocyte count up to 1,000, usually with a predominance of lymphocytes, but sometimes with a predominance of neutrophils in the early stage, a protein content of 1 to 8 gram to 800 milligram deciliter, and a low glucose concentration. However, any of these three parameters can be within the normal range. Acid fast bacilli are seen on direct smear of CSF sediment in up to 1/3 of cases, but repeated lumbar punctures increase the yield. Cultures of CSF is diagnostic in up to 80% of cases and remains the gold standard. Polymerase chain reaction PCR has a sensitivity up to 80%, but rates of false positivity reach even 10%. The ADA concentration, adenosine deaminase concentration, may be a sensitive test but has a low specificity. Imaging studies, CT and MRI, may show hydrocephalus and abnormal enhancement of basal systems of ependyma. If unrecognized, tuberculous meningitis is uniformly fatal. This disease responds to chemotherapy. However, neurologic sequelae are documented in 25% of treated cases, in most of which the diagnosis has been delayed. Tuberculoma, an uncommon manifestation of central nervous system tuberculosis, presents as one or more space-occupying lesions and usually causes seizures and focal signs. CT or MRI reveals contrast-enhanced ring lesions, but biopsy is necessary to establish the diagnosis. Various pathogenetic mechanisms are involved: swallowing of sputum with direct seeding, hematogenous spread, or ingestion of milk from cows affected by bovine tuberculosis. Although any portion of the gastrointestinal tract may be affected, the terminal ileum and the cecum are the most commonly involved sites. Abdominal pain and swelling, obstruction, hematochezia, and a palpable mass in the abdomen are common findings at presentation. Fever, weight loss, anorexia, and night sweats are also common. Now about gastrointestinal tuberculosis. With Intestinal wall involvement, ulcerations, and fistula may stimulate Ghon's disease. The differential diagnosis with this entity is always difficult. Anal fistula should prompt an evaluation of rectal TB. Because surgery is required in most cases, the diagnosis can be established by histologic examination and culture of specimen obtained intraoperatively. Tuberculous peritonitis follows either the direct spread of tubercle bacilli from ruptured lymph nodes and intra-abdominal organs, or hematogenous seeding. Non-specific abdominal pain, fever, and ascites should raise the suspicion of tuberculous peritonitis. The coexistence of cirrhosis in patients with tuberculosis peritonitis complicates the diagnosis. Tuberculous peritonitis. In tuberculous peritonitis, paracentesis reveals an exudative fluid with a high protein content and leukocytosis that is usually lymphocytic. The yield of direct smear and culture is relatively low. Culture of a large volume of ascitic fluid can increase the yield, but peritoneal biopsy is often needed to establish the diagnosis. Pericardial tuberculosis, tuberculous pericarditis. Pericardial tuberculosis has often been a disease of the elderly in countries with low tuberculosis prevalence, but also develops frequently in HIV-infected patients. Case fatality rates are as high as 40% in some series. The onset may be subacute, although an acute presentation with dyspnea, fever, dull, testosterone pain, and the pericardial friction rub is possible. An effusion eventually develops in many cases. Cardiovascular symptoms and signs of cardiac tamponade may ultimately appear. In the presence of effusion, tuberculosis must be suspected if the patient belongs to a high-risk population. If there is evidence of previous tuberculosis in other organs, or if echocardiography, CT, or MRI shows effusion and thickness across the pericardial space. Definitive diagnosis can be obtained by pericardiocentesis under echocardiographic guidance. The peripheral fluid must be submitted for biochemical, cytologic, and microbiologic study. The effusion is exudative in nature with a high count of leukocytes. Hemorrhage effusion is frequent. Direct smear examination is very rarely positive, whereas culture of pericardial fluid reveals Mycobacterium tuberculosis in up to 2/3 of cases. Pericardial biopsy has a higher yield. High levels of ADA and IFN gamma may also suggest a tuberculosis etiology. Without treatment, pericardial tuberculosis is usually fatal. Even with treatment, complications may develop, including chronic constructive pericarditis with thickening of the pericardium, fibrosis, and sometimes calcification, which may be visible on a chest radiograph. Miliary tuberculosis is caused by hematogenous spread of tubercle bacilli, although it's often the consequence of primary infection in children. It may be caused by either recent infection or reactivation of all disseminated foci and in adults. The lesions are usually yellowish granulomas, 5 to 2 mm in diameter, that resemble millet seeds. Thus, the term miliary, coined by 19th century pathogenesis. You see here miliary tuberculosis of the spleen. The cut surface shows numerous gray-white granulomas. Miliary or disseminated tuberculosis. The clinical manifestations are non-specific and protein depending on the predominant site of involvement. Fever, night sweats, anorexia, weakness, and weight loss are presenting symptoms in the majority of cases. At times, patients have a cough and other respiratory symptoms caused by pulmonary involvement as well as abdominal symptoms. Physical findings include hepatomegaly, splenomegaly, and lymphadenopathy. Eye examination may reveal choroidal tubercles, which are pathognomonic of miliary tuberculosis in up to 30% of cases. Meningissimus occurs in less than 10% of cases. A high index of suspicion is required for the diagnosis of miliary TB. Frequently, chest radiography reveals a miliary reticulonodular pattern, although no radiographic abnormality may be evident early in the course and among HIV-infected patients. Other radiologic findings include large infiltrates, interstitial infiltrates, and pleural effusions. You see here miliary or disseminated TB X-ray and CT scan of miliary or disseminated TB. Sputum smear microscopy results are negative in 80% of cases. Various hematologic abnormalities may be seen, including anemia with leukopenia, lymphopenia, neutrophilic leukocytosis, and leukomoid reactions, and polycythemia. Disseminated intravascular coagulation has been reported. Elevation of alkaline phosphatase levels and other abnormal values in liver function tests are detected in patients with severe hepatic involvement. The TST may be negative in up to half of cases, but reactivity may be restored during chemotherapy. Bronchoalveolar lavage, BAL, and transbronchial biopsy are more likely to provide bacteriologic confirmation, and granulomas are evident in liver or bone marrow biopsy specimens from many patients. If it goes unrecognized, miliary tuberculosis is lethal. With proper early treatment, however, it's amenable to cure. Tuberculosis may cause chorioretinitis, uveitis, panophthalmitis, and painful hypersensitivity-related plisteneural conjunctivitis. Tuberculosis otitis is rare and presents as hearing loss, orthorea, and lymphatic membrane perforation. In the nasopharynx, tuberculosis may simulate Wegener's granulomatosis. Cutaneous manifestations of tuberculosis include primary infection caused by direct inoculation, abscesses, and chronic ulcers, scopuloderma, lupus vulgaris, miliary lesions, and erythema nodosum. And the last slide is less common extrapulmonary forms that we meet. Adrenal tuberculosis is a manifestation of disseminated disease presenting rarely as adrenal insufficiency. Finally, congenital tuberculosis results from transplantal spread of tubercle bacilli to the fetus or from ingestion of contaminated amniotic fluid. This rare disease affects the liver, spleen, lymph nodes, and various other organs. Thank you for your attention.